We begin the procedure by placing the patient on a shoulder roll with their head moved towards the left. We prep and drape the patient, making sure to place the head of the drape towards the patient's foot. We then mark our surface landmarks with the clavicle, ear, and the trachea in the midline. We'll place a finger on the clavicle and identify the sternocleidomastoid muscle running cranially superior to the clavicle. We make our incision 1 finger breadth above the clavicle and dissect down to the subcutaneous tissue. We then identify the sternocleidomastoid muscle and separate the two bellies of the muscle vertically in order to identify the carotid sheath underneath. We will use a combination of blunt dissection and electrocautery for this portion of the procedure. It is useful to have a self-retaining retractor in order to help you better visualize the carotid sheath underneath. Now we can see the jugular vein and vagus nerve. Next, we will dissect out the jugular vein very carefully, only grasping the vein once in order to elevate it and dissect underneath. The more times we grasp and release the vein, the more it will cause the vein to vasoconstrict. We then place 2 silk ties underneath the vein in order to attain vascular control. We will snap these ties and place them down on the bed. Next, we will dissect around the carotid artery in a similar fashion to the vein, being careful to only grasp the artery when we need to, and then to place 2 controlling ties around the artery. Once we have control of the vessels, we can see the carotid artery, jugular vein, and vagus nerve. We now obtain the venous cannula and note that the cannula should go into about 6 to 7 centimeters at the venotomy in a neonatal patient. I typically measure the vein tip down to the nipple just to the right of the sternum. The arterial cannula should go in about 2 to 3 centimeters at the arteriotomy in a neonatal patient. Next, we will cannulate the arterial side. First, we tie off the cranial side of the artery and place a snap on it to place tension. We then control the vessel on the cardiac side and perform an arteriotomy using an 11-blade scalpel transversely through the vessel down about halfway. Next, we place 2 Prolene sutures through the anterior wall of the vessel in order to help avoid dissection of the vessel as we place the cannula. Now we very carefully place our arterial cannula down 2 to 3 centimeters while controlling the cardiac side of the vessel. After placing the cannula, we will have one of our surgeons hold onto the cannula while the other surgeon ties down one of our silk ties around 2 vessel loop bumpers on the cardiac side. The bumpers help to protect the vessel from necrosis from the ties and also help for ease of removing the ties when we are ready to decannulate. We place another silk tie around the cardiac side and tie it down for extra securing around the vessel loop bumper. Next, we take our cephalic ties and place them around the vessel loop bumper and the cannula as well. Finally, we will tie the cardiac and cephalic ends together in order to secure the cannula in place. Next, we carefully remove the obturator and allow blood to slowly fill up into the cannula. We take care during this portion of the procedure in order to lose as little blood as possible. Our assistant will place a tubing clamp on the clear portion of the cannula and avoid clamping down on the metal portion. Next, we place the venous cannula, first tying down the cephalic side and placing it on tension. We then control the cardiac side and perform a venotomy using an 11-blade going transversely across the vessel. Next, we obtain our cannula and place it down to our predetermined length, which is typically 6 to 7 centimeters in a neonate, or in a larger child, it will be the length that it takes to get the cannula down to nipple depth just to the right of the sternum. Again, we make sure to control for bleeding out of the vessel while placing the cannula. After we secure the cannula in place in the same manner as we did to the artery, we will allow for backfilling of blood into the cannula after removing the obturator and allowing blood to passively fill into the vessel. Now we will connect our cannula to our ECMO circuit tubing with one of our surgeons controlling the tubing and cannula and the other inserting saline into our connection area in order to get all of the bubbles out. We perform a wiggle maneuver in order to wiggle the tubing onto the cannula while getting it in place. We want to make sure we put no tension on the cannula while doing this portion of the procedure because a cannula can be pulled out of the vessel until it is finally secured. We then snap the tubing to the drape in order to help keep it in place while we connect the other cannula to our circuit tubing. Again, we use a saline flush to get all of the air out of the connection and check for bubbles before we finally advance the tubing onto the cannula. After we are on ECMO support, we will attain hemostasis in our neck wound, first by sucking all the blood out of the area and then using electrocautery to take care of any bleeding at the muscle level. We use a Prolene suture to close the incision, and then we secure each of our cannulae to the patient's skin using 3 sutures. These sutures can be braided sutures such as silk or monofilament sutures such as Prolene. Now you will obtain a chest x-ray and/or echocardiogram in order to verify tip position. Great work, team. You've cannulated the patient, and now they're on ECMO.